Hello, everybody, and welcome to the Doctors of Running podcast, where we, a group of doctors of physical therapy, discuss the art and science of running and the stuff that we put on our feet. Today at the round table, we have Dr. David Salas and myself. I'm Nathan Brown, so it's just the two of us. You are stuck with two, I was going to say sad NBA fans, but things have been turning around for the Warriors lately. So you're probably a happier guy or having a weird emotional reality right now. And I'm just sad because Chris Middleton is gone.
Yeah.
I get it was the right time, but it does make me a little sad.
Yeah. You know, sports teams sometimes they can act a little bit like a patella. Sometimes it just needs a little lift, you know, and Jimmy Butler is providing that right now. So
well, that's perfect.
Things are on the up.
I can promise you that none of you came here to hear us talk about our NBA fandom and the NBA, but you may be interested to hear us talk about patellofemoral pain syndrome, which is what is going to be mainly on the docket today. We're going to be talking about what is the definition of patellofemoral pain syndrome and what may people be referring to it as. We're going to talk about the science of it and what may be some of the pain generating structures, talk about some of the common ways to rehabilitate, things to consider, and are things like changing the way you move, gait retraining, gait mechanics, thinking about other factors that may contribute to this pain syndrome. How can you go about treating it and what are the biggest bang for your buck? That's where we're going to be going today. But before we go there, David, are there any shoes right now that you've been testing or you're going to get ready for review soon that you want to bring up and talk about?
Yeah, I mean, the majority of them I can't talk about, you know, but that's old news. The current one, though, that I can talk about is the Cloud Surfer Next. Kind of a fun shoe, continuation of the Cloud Go, which I didn't actually realize that until I was reading the Running Warehouse summary. And I was like, oh, that kind of makes sense. They made some changes. I think it is a different shoe than the Cloud Go, but there are enough similarities where I could kind of see that being a continuation of the line to some degree. But it's fun. Yeah, just wrote the review this morning. That should be coming out shortly, or maybe even before this airs. So,
where do you see that shoe fitting lineup wise, or is it a shoe that could do everything for somebody?
A little bit of everything, you know, it's definitely firmer. Like, yeah. I mean, even for On, this shoe's pretty firm, but there's still just enough cushioning. Like On didn't publish their stack height, but Running Warehouse has it at a 37, 31 for 6mm. So there's a decent amount of foam still, but it's right. But it is firm.
It is,
you know, and it's got kind of a pretty modest heel bevel, a little bit of a sharper toe spring up front. The foam has a good little bit of bounce to it when you load it. So it does have some versatility. It weighs in the low 9 ounces. So it's like you can kind of do a little bit of everything. You know, it's definitely, and it feels that way. Like the upper is a little bit more streamlined too. Platform itself's a little bit stiffer. There's a little bit of give to it, but it's still pretty stiff. Whereas like the Cloud Surfer is kind of like that traditional training shoe. Where I feel like this one, it's like, oh, okay, like I could do some tempo runs. I could do some long runs, assuming you're okay with it being that firm.
Right.
But I feel like there's a little bit more versatility to it. You know, it's not like you put it on and you're like, oh, I'm just only going to run daily miles. Like you could turn it up a little bit. Yeah.
I think it's interesting that they both the Cloud Surfer and then the Cloud Surfer Next are in the Cloud Surfer category, but they are very different because that Cloud Surfer, the original one from On, was the first shoe that was like remarkably soft,
right? From
On, like remarkably, and then you have this on the Cloud Surfer Next, which is again more back to that firmer feel. So it's just interesting.
Yeah, I think
in the same world.
From a naming standpoint, I don't have confirmation on this. But I think it's the midsole makeup and geometry. So with them using the Cloud Tech phase, that kind of indicates the Surfer line versus like there's no speedboard. It's just like that new midsole that they're working with.
Yep. They have the clouds are like angled instead of straight up and down.
I think that's why it's like in the Surfer lineage, but it's not in and of itself. They're not doing a great job of differentiating it though.
Right.
You know, where it's like, And I thought Surfer Next initially in my head, I thought it was going to be this like hyper responsive, super bouncy shoe, kind of by the name and the idea of like, oh, this is the training shoe and this is the light, fast one. Yeah. And I was like, I didn't quite get that, but it was still really nice. I did have good things to say about it. And I think it will serve a good population of people for those that want that firmer feel. But it was a little bit misleading, I think, for myself.
Yeah. Well, cool. So what I'm going to do next is we're going to start transitioning into our conversation on patellofemoral pain syndrome. I'm going to start giving us a breakdown of the anatomy. And then, David, after that, I'm going to pitch it over to you to talk about what is patellofemoral pain syndrome and what may we mean by that term, because there are lots of things that people use that term to refer to. So we want to get on the same page about that. But when we think about the knee joint, there's a couple things that we should know. One is that in regard to the region or body part that has the most running related injuries for runners, it is the knee. Over 50% of running related injuries happen at the knee, and 30% of the reason why people seek care for a running related injury, up to 30%, some studies show less than that as well, are because they have the symptoms of patellofemoral pain syndrome, or that becomes their diagnosis. So this is a very prevalent thing that happens in the running community, and that's why I wanted to spend time talking about it. When it comes to the knee joint itself, there's actually kind of two joints, maybe even three if you want to categorize a third one that within the knee joint. You have the tibio-femoral joint. So that's the two big bones coming together, your femur coming down from your thigh, the tibia being your big shin bone. Those articulate together. And then you have the patellofemoral joint, which is that floating kind of kneecap structure that articulates with the femur. It kind of floats on top of there. That's connected from the quadriceps tendon that goes into the top part of your kneecap or the patella, and then it goes down into the tibial tuberosity or part of that shin bone. A few other structures that I think are worth just kind of wrapping your mind around are the fact that the tibia and the femur come together. Between there are two menisci, and then also holding the knee together are a bunch of ligaments. So you have these ligaments inside your knee called the ACL and PCL. They're called your cruciates. They cross each other. Then on the outside of the knee, you have collateral ligaments, which are just thickening of an entire sheath that surrounds your entire knee. Every joint has this capsule of a thick fibrous tissue. And within our knee, we have this a capsule that surrounds the whole thing. And then we have some thickenings with the MCL on the inside of your knee, the LCL on the outside of your knee. I think additionally, something that's important to know is that the knee, because it's a joint, it articulates at what's called hyaline cartilage or articular cartilage, very smooth surfaces that glide really well on each other. These exist both at the tibio-femoral joint and the patellofemoral joint. And we're going to talk a little bit more about cartilage as we move on in this conversation, but it's important to remember that the cartilage also exists. And then under that cartilage is bone. Any other anatomical things that, I should say, the third joint that sometimes people may put at the knee is what's called the proximal tib-fib joint. And so that's right at the top of your shin. There's two bones that kind of come together. There's not a lot of motion there. There's some translation that happens at that joint, but typically that translation is more associated with ankle motions than it is with the knee. So we're not going to really talk about it much, but some people may be like, well, what was that third structure?
I was kind of curious. I was like, what is the third?
Yeah, what is the third one?
And it's like, if I looked a little cheeky on video there after, I was like, yes, kind of.
Yeah, and that's why I don't really put it there, but somebody may, and so I didn't want to leave it out. Obviously, too, on the outside of the knee is your iliotibial band that comes down and attaches to the fibular head. Also, flows into part of the patella and lots of different regions on the outside. Gertie's tubercle on the tibia. So there's lots of different things going on at the knee, but it's a nice little hinge joint. Flexes and extends. It's got a little bit of rotation to it, which will come into part of our conversation as well. So I'm going to give you an opportunity. Is there anything about anatomy that you want to add, or do you want to just start talking about what do you think of when you think of patellofemoral pain, and what do other people may sometimes refer to it as?
Yeah. So when we look at it, I think anatomically, I think you hit it pretty well. I'm not really sure there's much I can add there. That was a pretty good summary.
3 minutes too much.
No, that was good. That was a compact, that was a crash course in knee anatomy right there. I was pretty solid. I was like, oh, dang, that EDD is paying off there. Okay, I see you. For those of you that don't know, Nate's working on an educational doctorate here. So
I should defend, I don't want to put it too public, but potentially defending and finishing up end of March. So
yeah. I got to see Professor Nate there for 5 seconds. I was pretty impressed. Or 3 minutes, not 5 seconds. But no, I think you hit it pretty well. I think it's kind of funny when we look at patellofemoral pain syndrome, as common as it can be, it also is a little bit diffuse and kind of hard to define. And there's a lot of people within our own field that will kind of butt heads a little bit on what is patellofemoral pain syndrome and what are the true pain generating structures and what's actually going on at the knee. And because of this kind of mystification of the joint, it can be hard there's a lot going on at the knee, like you just identified. And in a lot of pathologies, you have a very specific structure you can point it to. And we'll get to this later, but like we were talking before coming on, like one of the things that can all get brought up pretty frequently when we talk about the knee is like patellar tendinopathies and things like that. That's not exactly what this is, right? Like that is a tendinopathy of the patellar tendon itself. When you're looking at patellofemoral pain syndrome, I'm usually looking more specifically kind of at the patella and the surrounding connective tissue there. And so usually it's kind of a broad-based anterior being in the front knee pain, and sometimes even within the retropatellar space where you're looking at the patella itself and then the little gap that you have in between. Let's say you have your big femur, your tibia, and then you have that floating kneecap right in the middle. And then there's a little bit of space in between there. And so sometimes people get this irritation and pain on the underside of that, or even on the inside wedge of that. And so when you kind of get those like weird broad-based kind of front of the knee pains, that's kind of what I usually think of as patellofemoral pain syndrome versus a traditional tendinopathy or ligamentous injury or something like that.
I totally agree, because I think when people come in and they end up, in my mind, having that kind of diagnosis of patellofemoral pain syndrome, there usually isn't a palpably tender structure like the patellar tendon is super tender to palpation, or if they have really inflamed fat pads. I kind of categorize that differently from patellofemoral pain syndrome, which I find to be, like you said, more retropatellar, deep to that kneecap, in that space between. There's kind of just this ill-defined, sometimes it's more medial, sometimes it's in the middle, and it's just kind of there, but they can't they can't point to it. They can't push it. Oftentimes that's what I categorize as patellofemoral pain syndrome. But that categorization, even when I give it to people, I'm not telling them it's this structure that's causing you the discomfort, because I went through a lot of those structures that are in the knee. And with this syndrome, it's ultimately a result of when your capacity and your loading don't match up. And so the amount of loading that you had in that patellofemoral space is exceeding what the capacity is at that time. And then that may lead to irritation of a number of things. I think there was some studies that showed that the edema, not within the cartilage, but the bone underneath the cartilage, there's edema there that causes some discomfort on that backside of the patella. That was one theory. It also can be that membrane, that kind of capsule that I talked about, getting irritated. And I think that makes a lot of sense because of what we know about how much loading there is related to running. And yes, we adapt to the load that we put on our body. But at some point, if you have a decreased capacity and your load exceeds it, you can start to have discomfort. They did some math in a study. I wrote it down because I thought it was interesting to think about how much loading happens to your knee when you run. And I want to be clear before I read these numbers. Loading is not bad. In fact, loading in your knee joints, we have a whole podcast on this, actually helps prevent degeneration of your knee. It's running recreationally is protective for knee joint health. But anyway, listen to the amount of loading that happens. If somebody is running 160 steps per minute, which is potentially conservative with some people having a higher cadence than that, and each time you step, there's about 4 times your body weight that goes through the patellofemoral joint. That is 320 body weights per minute going through that joint and 19,200 body weights per hour. And then you extrapolate that further in the number of runs that you do in a week. That's a lot of loading that joint needs to respond to, recover from, heal from. And it makes a lot of sense to me that it's possible that the area underneath that cartilage can get a little bit of swelling as it's repairing itself, and that can lead to some of that discomfort. And you need to be able to manage kind of some of that load. What's also important, because I think sometimes people also, again, get scared that running may be decreasing the health of their cartilage. And then when their cartilage starts breaking down, they're getting osteoarthritis, and that can lead to pain. What's really important is that there's previous research that shows that there are not nerve endings within our cartilage. So if you have something like chondromalacia, let's say you had knee pain, you go to an MD, they're probably going to give you x-rays, and that might show that there's some sort of chondromalacia. But chondromalacia cannot be really a cause for pain because the cartilage itself cannot be a pain receptor. There aren't free nerve endings in those structures. And so what we do sometimes is say, oh no, running's leading to softened cartilage, which is leading to my pain. I need to stop running. And that's not the case. We need to be thinking a little bit differently about this. And it's more about load management so that you can continue to ramp up the amount of loading that the tissues can tolerate. Do you have anything to add?
Yeah.
I just rambled for a bit.
No. It's a very professional and a very doctorate level rant.
I don't like this.
I'm just going to for those of you that don't know our relationship, I will
David
find
troll.
something to just troll him constantly about, and then I will just lean into it for way too much time.
I'm screwed now.
I lost my thought. No. Okay, so for anything, when you look at specifically in the physical therapy world, there is this is going to be one of the few times I bring up APTA here, but there is a push to have clinical practice guidelines and things to follow, and kind of have kind of a roadmap and kind of what is something, what are some things to look for, what have some of the studies said about it, levels of evidence, going into everything between exercises to motor control, gait training, modalities, yada, yada, yada. So those exist. If you guys want to go out and find that, that is public information. You can just literally look up, patellofemoral pain syndrome, clinical guidelines, boom, it'll pop right up. Usually JOSPT, that's Journal of Orthopedic and Sports Physical Therapy. Yep, there we go. Yep. Sometimes I'm so used to referring to things as acronyms that I'm like, what is the
what does it actually
acronym
mean? Yeah.
100%. But anyways, like some of the things with patellofemoral pain syndrome, like we were saying, it can be kind of broad based as far as like, okay, what is actually happening there? And it's like, I think you did a really good job of kind of summarizing that it's kind of an issue between load and capacity. But some of the things that are believed to kind of be some of the things that start it, number one is like overuse, right? You're just doing too much and something gets irritated. But there are some reasons to believe too, like let's say you don't have the proper strength to be doing what you're doing. And so that's just a mechanical issue there. Like you just can't produce the force. Something's getting irritated. Sometimes it can be a motor control issue where it's maybe not a strength issue, but the way you're moving on a given area is creating irritation within that joint or joints, as we can say. And then sometimes it can be a strength issue elsewhere as well. So like a lot of times, I'm sure if you've seen a PT for things that are similar, they will tell you like, oh, let's look at your hips. Oh, you have no hip strength. Maybe we should work on that because that can be protective for your knee as well. So I think there's a lot of kind of differential diagnosis and a lot of kind of screening when you're on the clinician side of things to be careful and look for. And it's not as simple of just, okay, let me take a look at your knee range of motion. Okay, range of motion looks okay. Let's look at your quad MMT. I don't know, your quad looks pretty strong. Like, I don't know what's going on. It's not that simple, right? Like, and so I think it's good to look at it. Oh, and the other thing could be potential mobility issues as well. If things aren't gliding well or they're not able to elongate certain things, and that can create also passive tension on something, and repetitive tension can get irritating after a while if it's not able to move through a normal range of motion dynamically. So that is my rant.
That's great.
Yeah.
Very much less professional.
Yes. as I like to keep it.
Gosh, now I just played into your own troll of me. No, so I think what can be so frustrating about patellofemoral pain is it kind of comes out of nowhere. A lot of times runners are like, and even myself, when I've dealt with it, it's like, it doesn't feel like I did anything different. It doesn't feel like I did anything crazy. And all of a sudden my knee's just bugging me. And I think that's where kind of the scales balance of load on one side and capacity on the other side can be a helpful thing to not underestimate the power of one of the factors that can lead into this. As I was preparing for this, I went back and looked at an article from 2020, and it laid out some nice things that impact load and capacity. So some of them for load that we may not give enough credence to is if you start to add more speed into your workouts. You have more speed work in there. The amount of load on your knee goes significantly higher. Obviously, mileage. That's another one that's a little bit more obvious. If you increase your mileage, you're going to have more load. As we go back to like some of those numbers of how many body weights per minute and per mile. And then you look at if you're running uphill compared to flat, that increases loading on the knee joint. Going downhill significantly increases patellofemoral joint loading. And then we're going to talk about footwear later, but some footwear can increase the amount of loading on the patellofemoral joint. Your gait mechanics and how your knee is tracking in the frontal, meaning like from the front and from the side, can have an impact on the amount of patellofemoral loading. And then if you're doing other activities, maybe you're like, you know what? I'm going to go play with my kids, a couple times a week, or I'm going to go on an extra hike, or I'm going to actually add in some strengthening, or I'm going to add in some plyometrics. That additional amount of exercise or activity is more load that the knee needs to handle. And then on the other side of the scale is capacity. And these are ones that are sometimes harder, to quantify, but they're some of the very basic 98% of our health. So like if you have increased stress or anxiety, your capacity is going to go down. If you have less sleep, your capacity is going to go down. If you have fatigue or depression or kinesiophobia or fear of movement, poor nutrition, all of those things can lead to a decreased capacity for that tissue to handle load at a given time. Great example for me was when I was training for my first marathon and things were going great. And halfway through our training, we had our first son, Henry, which was great. And then my stress and anxiety went up trying to learn how to take care of a human. And my sleep went way down. And I actually wasn't in an increase in loading, but I ended up having a significant injury that really hampered the rest of my training. And so your capacity, if that scale gets really tipped in one direction, even if you haven't changed your load, you can be predisposing yourself to some injuries. What I want to move on to next is to say, okay, now you have this patellofemoral pain syndrome. What does the rehabilitation process look like? What are some things that you can maybe start on your own? When do you need to go see a PT? What's kind of your perspective there?
Yeah, I think that's a great thing to bring up and transition to, I was going to make a cheeky professional comment, but I'm not going. I'm going to refrain myself. But I think it's when it starts affecting the things you want to do, obviously. So i.e. if it's running and you can't run, I mean, that's one thing there. But sometimes it's other things as well. It's like if you have a hard time going downstairs and you're like,
Yep.
Shoot, man, I can't, like, every time I go down those things, like I just get that pain right on the front of my knee. I can't figure out what it is. Or even immobility can do it. Let's say you're sitting at your computer desk and you're working, you're doing things, and then it's like you try to get up and move around every once in a while, but every time you do, your knee hurts. And so and we call that a theater sign. You sit down, you watch a movie, you get up, it's like, which can be consistent with other knee injuries as well. But, basic screening things for yourself and looking at just how are you doing, right? Mm-hmm. I mean, most of the time with patellofemoral pain syndrome, you're going to get it with things that have some level of loaded knee flexion and or immobility. And so, i.e. the things that have loaded knee flexion are things like running, squatting, stepping up onto curbs, coming off of stairs, right? Like things like that, especially in unilateral situations, right? Like when that leg is isolated and it doesn't have help. So I think if you're starting to notice some of those daily issues and you're starting to think about it more and more, it's not just like oh shoot, I wonder what happened. Sometimes things just go away. Sometimes they don't. So when things don't and it starts to become a recurring theme and you're like, I don't know about this, something's weird, that's probably the time when you should probably start looking for a professional. Mm-hmm. On the professional side of things, I think when you look at a patient, I think you do have to be, I think PTs in general tend to be a little bit more holistic thinking in the medical practice, but nothing is ever as simple. And I kind of alluded to this already. It's not just the knee. And so you have to kind of look at the whole body and then look at the impairments that are present, look at some of the secondary factors like you brought up, stress, sleep. I think kinesiophobia is a really important one. I'm happy you brought that up. It's a very fancy word. I was very happy to hear that. but your fear of movement, your fear of your own body can really accentuate that nervous system, and that can have pretty massive effects that I don't think people give enough credit for, truly. Trolling aside, like that is something that I think if you are afraid to move your body, then everything's going to be hurting. Everything's going to be a little extra sensitive. Your nerves are going to respond to that, you know? And I think for those that have a lot of anxieties around training, especially if they have a history of a lot of injuries, that can play a role. That can play a very real role. So I'm happy you did bring that up, truthfully. But looking at it from a clinician, I think it is good to look at the body you have in front of you. We always say the 2-joint rule, right? Look above, look below, you know, clear out anything else. Is there anything neurologic going on? Is there any, in the PT world, there's like special tests and things like that. Is there something differentially going on? Is there like something in the meniscus that might be a little irritated? Because also loaded knee flex positions, the menisci don't always like that if they're irritated. And just looking around, like, is there mobility? Are things moving well? Is the foot and ankle moving well? If that's not moving well, you're going to have a lot more load going through that thing, right? Like you're not going to be able to dissipate forces as well. So just things like that to really kind of look all around, make sure you have good mobility, make sure you have flexibility where it matters, whether it's the calf complex, the hip flexors, the quads, and then making sure that you have the base amount of strength to do the things that you want to do as well, because that is important, right? And again, not just the quads, not just the hamstrings, not just the shins. We're looking at above and below there too. Like, how is your calf strength? How is your, you know, your glute max, your glute med? You know, a lot of people always focus on the glute med, but it's like your glute max is a crap ton of stabilization as well.
Yeah.
Like, why are people not looking at this? Yeah.
Totally.
So things like that, just making sure that you have a good supporting structure to do the tasks that you're asking your body to do. And a good PT will go through a screen and look through everything. And then they'll let you know, like, hey, like, I like this, this, and this, but we could probably work on this, this, and this. And I think that's kind of step one, is kind of control the controllables, see where that's at. And then to take a good look screening wise at the activity of the individual, like you were saying earlier, like, was there any increase in activity? Was there anything that was added in that was a different stimulus, be it physical or not? You know, if they started a new job and they just moved to town, they're going to be pretty stressed out. So it's like things like that, and being able to look and just take that step back and, again, just look at it very holistically, because this is kind of a weird injury where it's kind of diffuse, and it's frustrating for the patients too when someone goes poking around and they're doing it and they're moving it around and nothing's really recreating it very well. And it's like, sorry, I don't really know what to tell you. I wish I could just tell you this was the issue. That is what hurts. We do this, that gets better. Right. And sometimes it's not as black and white as that. So that is my rant on the patient and clinician side of the starting steps of this.
Yeah, and I agree with like everything you said, because I think something you mentioned even earlier too, or whenever it was, you talked about, you know, and then you're going to test their quad and do a manual muscle test, and that's going to look good. And it's going to be like, what is going on here? Yeah. And I think a couple things that are helpful to know. One is that kind of unequivocally, even regardless of your starting strength position, they found that doing strengthening of your quadriceps and of your gluteal muscles helps. So whether or not they're strong or weak.
I should put a caveat there. Yeah.
Yeah. Like, I think it's just
a 5 out of 5 strength means quote unquote normal strength for like normal tasks, right? Like, like it's a very basic, quick and dirty screen to make sure that there isn't any major abnormalities, right? That doesn't necessarily mean that you have the strength to go bomb a downhill down a mountain, right? Like that
run 40 miles a week.
Yeah. So the caveat there.
Yeah. And I think too, and I think you'd agree with me here, as professionals, we're limited by the tests that we can perform with the technology we have. So we may have just our hands, or we might have a dynamometer where we can test how many pounds of force you can produce with like a maximal push. Some people are going to have these isokinetic machines where they can test, you know, the amount of force you can do at a certain speed. There's lots of different types of technology, and they test different things. So I know for me, I've never really had more for most of my career than my hands or a dynamometer. And that just gives you like max force output But when we're running, we don't really use max force output ever. We're doing these quick repetitive contractions of our quadriceps and our glutes, and it's coordinated. So it like has to do with coordination, it has to do with power, it has to do with this fatigability. And we don't really get to measure that. And I think that's why some of these things, like even if you don't have numbers that show that you're weak, or it doesn't pop out on you when you're doing your clinical testing, it's still a good thing to probably work on this stuff with specificity towards the activity.
Totally.
And yeah, so I think those are some important things to consider. And I was also just going to reiterate the idea of the entire kinetic chain, checking above and below, and making sure the knee is sandwiched between two different joints that can move in a lot of different planes, and the knee is meant to go like forward and backward, and it can rotate a little bit at the shin, but that's not what it's made to do. And so it's kind of at the liberty of your hip joint and your foot joint, and having somebody help guide you through some of that could be helpful.
Yeah, like if any of my patients are listening to this, like a lot of times I say it's just a middleman. It just does whatever the hip and the ankle tell it to.
Right.
Like it's just like,
yeah, that's good.
Yeah.
I think in that vein, right there, I think it brings us to kind of this question about mechanics. And what is the value of understanding your running gait mechanics or your squat mechanics or your single leg step down mechanics, and how that may or may not influence patellofemoral pain syndrome?
Yeah, I think that's great that you brought that up. I think there's some big glaring things to look at, but I think generally speaking, I like to use the quote unquote normal, or the thing that I'm relating something back to, as their normal. So if they have an asymptomatic side and a symptomatic side, well, what do things look like on the asymptomatic side? Unless it's something glaring, right? Like, and we know this with like gait retraining, right? Like if you go and you completely change up the way someone runs, sometimes it predisposes them to another injury something else. Yeah. And so unless there's something just massively off, then I really don't go in that avenue as much. But let's say if we look at a step down, and for those listening, you usually will have a box, I don't know, give or take 6 to 8 inches. Yeah. Someone's going to put you on it 1 foot and have you take a step down to the side and or forward. And then they're going to look at the knee that you're standing on the box and see how it acts as you lower down that other leg. And they're going to tell you, well, they'll probably look at how you do it first without telling you anything. And if your leg looks super squirrely, it's rolling in, the whole thing has a giant valgus on it, it's like, okay, maybe we don't have very good control over our leg, but when you're running and you have that much load going through, some degree of internal rotation is necessary to have a little bit of shock absorption. A lot of it is controlling external forces that are placed on you from gravity and the amount of forces you're putting into the ground. So I don't demonize some of those movements as much as some other PTs may. But at the same time, I just want to make sure it's not glaring, because if it's really rolling in, like, okay, yeah, that's putting some massive pressure through that thing. We don't want that. But if it happens a little bit and it's consistent and it looks different between the two sides, like maybe one it's really rolling in and the other one's fine, or one it rolls in a tiny bit but it's fine, and the other one it rolls in about the same but it's shaking, like it's like, okay, well, maybe they don't have the proper stability needed, and maybe it's not so much a what am I looking for here? Like a motor control issue as much as it is just a pure strength issue in that situation. So kind of teasing out little things. And same goes for like running. If you see them and they're running and they take a step on that standing leg and that hip or that knee or something, it just drops, and they just have no control, or they just flex at that knee a lot more. Like they're just having a hard time holding themselves up through that side, whether it's the hip or the knee or the calf, and they're not pushing off very well. And the other can go too as well, like looking at maybe that looks okay, but like maybe they're just a little bit tighter on that side, like just can't extend that hip, and their stride length is altering and it just looks funky. Sometimes that can be it as well, where like maybe things are moving okay from a strength standpoint, but they're not moving okay from a range standpoint. And that's not necessarily something that they could get on a table where it's like, okay, lay down, bend your knee. Looks like you got 130 degrees. I don't know. It looks good. I don't know what to tell you. So when you look at some of those more functional translations in our world, functional limitations, right? Like find the thing that is limiting for you that you can kind of pick something up on, and then compare and contrast and look and see if there's any differences that are worth noting and anything that's worth working on.
Yeah.
And that's going to require some level of trust with your clinician as well, of who you're working with. And any clinician that you're working with, don't be afraid to ask questions. If they are a good clinician, they'll be happy to answer all questions. And if there's a gap in the knowledge or something they just aren't quite sure about, they should be able to tell you that too.
Yeah, hopefully they're honest with you.
Yeah.
That they don't know.
I like to think that I'm brutally honest, but I try to be very, very transparent as a clinician. But yeah, looking at things from those lenses and angles and just trying to just widen that lens, essentially. Yeah. Look at everything. Don't leave stones unturned. And find what is it that you're having a hard time with. Okay, well, let's look at it. Let's figure this thing out. Because sometimes, every once in a while, you get someone who comes in, oh, I'm great with everything. It's just when I do this.
Go to that thing.
All right, cool. Let's look at it. Let's figure it out. Does that matter? Like, is that something that's important to you? It is? Okay, let's look.
Yeah.
Because, I mean, it could be something as simple as like getting into a slightly deep squat for gardening, right? It might not be running.
Right.
So just random things.
Yeah.
Looking at all of that stuff.
I think I have a few thoughts regarding mechanics. Some of them are within like a diagnostic analysis, that side of thing. And then there's like the exercise and treatment side and kind of load management. So if I start on the first side of some of the assessment, you talked about how you can do some of these assessments. And then I'm going to talk specifically about running gait analysis. And because I use 3D running analysis with the runners that I work with. And right now, the evidence, shocker, isn't super clear about the association of running mechanics and certain specific injuries. There's some theory that if in the front, like looking at someone from the front, if their knee, like you said, is coming in and rolling in one way or another, both rotation and into adduction of the hip, that could increase the amount of loading at the patellofemoral joint. The research on big groups isn't super clear. Part of the question,
it would be.
Right, because some people just have that mechanics. Look at Connor Mance.
Yep.
And
everyone does. Like that's why I made the caveat of like some internal rotations normal.
Right.
Right. Like you're gonna have some of it. Like yes. And like I was really happy with some of my early rotations looking at like valgus in the knee. And for a lot of sports, you have to. You're playing basketball, you're making a cut, like you're gonna have to put a load through that knee in a valgus moment. Like people gotta be good at that to some degree, depending on what the tasks are that you're trying to ask it to do. So that's why I try not to demonize it too much.
And what's so important with that too is if somebody has been running that way for 15 years, your body adapts to the load that you put on it. And so it's not like that's the thing that's tipping them over the edge necessarily. They may have had a change in their mechanics for some reason. And that's where I think sometimes there's individual application to modifying the amount of frontal plane motion that somebody's having. Additionally, maybe if you do change that, you can change some of the external load that's going on in their body. But I think it's important to remember that if you run a certain way, don't let someone tell you you're running with terrible form. And because if your body has been running that way for a long time, it's adapting to that type of running and your tissues have to adapt to it. But again, there may be instances where you can apply that. I think where there's a little bit more credence sometimes is looking from the side. We call that the sagittal plane, and looking at how much forward translation of the knee is happening with your running mechanics. If you have a lot of anterior knee translation, the further that knee comes out and forward in front of your like in front of your toes during the running cycle, that just does increase the amount of loading. That doesn't mean you can't go back to running that way for the rest of your life. But in this moment where you have high irritability, a simple change of getting your foot off the ground more frequently by increasing your cadence has been shown to decrease overall patellofemoral joint loading. So if you're someone who's running with a really low cadence, maybe you look on your watch and it's like in the 150s, maybe you look at increasing your cadence by 5 to 10%. I tend to recommend doing this with a provider who can like understand what these gait mechanics are going to mean for the rest of your body. I think that's important.
Because
you said you could run into another injury. That's the tricky part. I do think cadence of 5% increase from your self-selected overall decreases loading on pretty much everything. So that's probably a safe one to try by yourself. But even when you do that, I recommend backing yourself down before you just like keep going. But anyway, I think under the supervision of a provider who understands the gait mechanics, doing some minor changes in the short term can be helpful to decrease that load versus capacity scales. Similarly, I think that doing exercises differently, like let's say you're someone who's hurting with squatting, but you want to strengthen with your feet on the ground and do single leg stuff, maybe you change how you do a squat or a lunge for the short term to decrease patellofemoral loading. I show this picture. I drew it on, if you're watching on YouTube. I was
wondering what you were doing over there.
Yeah, I was just writing this down. A little something. Chris Powers is a researcher out in California. He's actually in Southern California. He's down at USC. But he's done some research to look at what are the joint compressive forces happening, and can we just correlate that with clinical measures that we can get with an iPad? That's like his, which I really appreciate because it makes some of the decisions about kinetics and forces a little bit more accessible to us as clinicians. But basically, if you look at this here, we have from, is this on the left side for you, David?
That is on the left side for me, yes.
So from left to right, you have three different squat forms. One is where the trunk is angled forward more than the shin. The second one is where the shin and the trunk are angled about the same. And then the third is where the shin is more vertical or more angled forward than the trunk. And the more you are to the left, the less forces there are overall at the knee and the less joint compressive forces, whereas more on the right, it's going to have higher joint compressive forces. Doesn't mean that one squat is better than another. It just means that it's going to increase or decrease the amount of loading at the knee. And if you are having like this kind of more irritable patellofemoral pain syndrome, maybe you adopt a movement strategy for your exercises that's more like the one on the left, where your trunk is a little bit more forward, your shins are much more vertical. That can make a difference for just continuing activity without having super high loading through the joint. So I think that's where mechanics can play a role too, in a more like, or even applied.
Not to cut you off, but even like barbell placement, like front squat versus back squat versus hex bar versus, And so when you have, let's say, if we're talking just traditional front squat, back squat, like front squats can be more anterior on the front, that's going to load those squats a little bit more.
Right.
It's usually going to have a little bit more of an upright posturing, like you were saying, like in order to balance it out and keep yourself up here.
Right.
Versus like traditional back squat. I don't have enough space here. But like when you have it racked up on the spine of the scapula there, if you're traditional high bar, for the people that out there that are super into weightlifting, it's high bar and low bar and whatever. But anyways, posterior position back here, it's going to load those glutes a little bit more, going to put you in a little bit more of a different position as well. So that can also be a quick fix as well. Not fix. I don't want to say fix, but that can be a quick adjustment or modification. If you are like, dang, it's just like, I just can't front squat very well, but for some reason, when I put it on my back, it feels okay. You're probably okay.
Yep, exactly. So what I want to move to next is talking about
tacos.
Most people, tacos, of course.
Sorry, that was unprofessional of me.
No, well, I was going to say, I went to Houston. I went to Texas for the first time. I got to meet our audio engineer, BJ, for the first time in person. Matt and I all were together for lunch, and we got fajitas. And I almost am so glad that I didn't get tacos, because then I don't have to compare Santa Barbara tacos from David's wedding with like the meetup with BJ in Texas tacos. I have fajitas, which I loved, and I have tacos, which I loved, and I don't have to pick a favorite. I just love them both. So what we're going to do though, is going to continue talking about shoe footwear decisions now. And we're not even going to belabor the fact that obviously evidence isn't going to show us something. We're going to talk about what we've learned about footwear, the changes that it has in our mechanics, what sort of considerations you may make, knowing that this is not the biggest change or the most accessible or feasible change to make, because it would mean you might need to buy a whole new pair of shoes. But if you are someone with a lot of shoes available, we're going to talk about what sort of implications may different designs have for the amount of patellofemoral joint loading. So what are your considerations for patellofemoral pain syndrome in shoes?
Yeah, it's such a loaded question because there's so many theoreticals and different situations. Exactly. I think it can be very, very individual dependent on this. And the main reason being is that certain shoe designs, you may have a slightly stiffer range of motion that you go through, being like, let's say the high stack, stiff rockered shoes. You're not going to go through quite as much range of motion at the ankle. And you're going to have a little bit more at the hip and at the knee there. traditionally speaking, that's going to load your glutes and quads a little bit more. But in some situations, that can still help with the patellofemoral pain syndrome. And the reason being is like if it's coming because you can't move through a larger range of motion. So like let's say in the more traditional like lower stack shoes, a little bit more flexible design. I'm thinking like a Saucony Kinvara or a traditional Ultra or something. Like those kinds of shoes, they're a little bit more flexible designs. You move through larger ranges of motion. Usually you're going to have a little bit more work at the ankle and in the calves. In theory, that would take some work away from the knees and the hips, right? But for some people, like you do go through larger ranges of motion. So if you are someone that is sensitive to going through larger ranges of motion, then maybe that thicker high stack rocker profile. If you're someone that's like you're not as sensitive to that, or you need to stiffen up a little bit. Yeah, you go rocker. I'm losing myself here.
No, you're making sense to me.
Yeah, but if you need to unload the quads a little bit and it's more of a true strength issue, and you're like, okay, I need to switch this up, you can go switch design to something that's a little bit more, dominant on the calf and in the ankle complex. I am not as well tuned to lecturing as you can see.
This is the worst. I don't like this troll. This is not my favorite troll, which is fine. That's the point. That's why you troll me. But I've the only thing I'll add into this, because I agree with everything you've said, is that there's some evidence to show that those really high stack shoes that are really compliant, those smushy things, decrease the amount of motion we go through at our joints because it's not as stable of a platform. So we kind of reflexively stiffen. And like you said, if you're doing poor with more knee flexion as you go through your running gait, those higher profile shoes, which are going to be more rockered, might be your better choice, even though the rocker technically also shifts load up. So yep. it literally is one of those where, like, you just got to go try it and see what your situation is. Or like, let's say you're working with your PT or even you're by yourself and you notice that it's like, you don't get your pain until you're like doing a single leg sit to stand or something. And it's not till deeper. You probably could go to a shoe that allows you to go through more flexion, that has more forefoot flexibility and a little less stack. But if you're getting that pain right away, maybe you'd be thinking about a shoe that gives you a little bit more stiffness up top. So yeah. So how's that for a non-answer, everybody? It depends. It just really depends on how it presents for you. So, before we wrap things up, do you have any other things you want to add about patellofemoral pain syndrome?
No, just that it's diffuse and it's a little odd, and we fully acknowledge that. And I think anyone who has read up on it or is exposed to it, which would be most PTs, I would assume, it can be a frustrating one. So if you're listening to this and you're frustrated, it can be frustrating for both parties sometimes. Yep. And so a lot of it is figuring things out and working through it together. It's not as straightforward as some of the other pathologies that are out there. That's probably my closing thoughts on that.
Good. Yeah. The last thing
tacos can help.
Tacos always help. From California.
I don't know, man. I'm not a hater of like regionality here. I can fully acknowledge. I'm sure Texas has some good tacos. So when I asked you, like, hey, who has the better tacos, and you went and skipped out on me, I'm like, I was a little hurt. I'm not gonna lie.
Wow. We'll have to go back to Texas then.
Yeah.
I guess I can't even remember what I was gonna add. So maybe we'll just wrap things up. Does that sound good? I can't remember the thing I was going to say. This is what it was. I wanted to just reiterate that this can be, as you said, a frustrating and nagging thing. That doesn't mean you need to go get imaging. There are very few instances where this is going to be some sort of like major degenerative condition. The signs and symptoms would be very different for osteoarthritis than they are for patellofemoral pain syndrome. And this is one of those conditions where it's like, I have a major bias here, but I wouldn't waste your time going to someone who doesn't do rehabilitation. Go to someone who does rehab first for this, because you're going to probably have to pay for an x-ray that's going to tell you something about your knee that you didn't want to hear, but doesn't actually have anything to do with your condition. So go to the rehab specialist first. And I think that you'll not necessarily get better at the snap of a fingers, but you're going to get on the right track quicker. Sounds like you had something else that popped up for you.
Yeah, I think in most situations that applies. I'm happy you brought that up. I was just speaking of like frustrating and inconspicuous and other stuff. Is Giannis back? Is he healthy?
Gosh, you
I know he
would
didn't
bring
play
that.
in the All-Star game. Yeah,
Yeah,
how's he doing?
he's been back. He's been playing.
Okay.
So
I'm not a Giannis hater.
You just troll me with him.
I
It's
just
fine.
troll you. He's a fantastic player. He's a good person from what I can tell. He's an easy guy to root for.
Yeah, he is. He is. Yeah, we'll see. I think final take, and then I'm going to close things up. This feels like a potential make or break year for Giannis's like finishing his career with the Bucks.
Really?
It's just the feeling I have. I could be totally wrong, but I think that they made a lot of changes to try to continue to make the Bucks competitive. In the process, you lose Drew and you lose Chris Middleton. You get Dame, and now we have Kyle Kuzma. But I think what's challenging is those two guys were part of the championship run. And you see Drew, and he joins a team. They go win a championship.
Oh, Drew's phenomenal.
Drew's just a great guy to have on the team. So they're doing some experiments. And if it doesn't work out this year, if they can at least make like the Eastern Conference Finals, I wouldn't
just trade Golden State.
I wouldn't blame Giannis or be that surprised if he ended up trying something else, as much as I want him to stay here forever. So with that said, I'm going to wrap things up. We are going to close things down. If you want to have us cover anything else with Doctors of Running, you can send us an email at doctorsofrunning@gmail.com. Thank you for joining us in the podcast, and we'll see you next time.